Psychiatric Concerns in Women on Audio Digest Psychiatry, Volume 25, Number 2. First, the connections between victimization, post-traumatic stress disorder, and Bulimia Nervosa by Timothy D. Brewerton, Associate Professor of Psychiatry and Director of the Eating Disorders Program, Medical University of South Carolina. He first reports results of the National Women's Study.
There are several types of legally defined criminal victimization, all of which are against the law, and they include rape, contact sexual assault or molestation, attempted sexual assault, aggravated assault, and direct assault being any of those defined above, and I'll share with you what we mean by each of those. But basically, I had the opportunity at the Medical University to get involved in a study looking at the effects of these types of criminal victimization on the development of eating disorders. And this work was done in conjunction with Drs. Bonnie Dansky, Patrick O'Neill, and Dean Kilpatrick, who was the chief or principal investigator on this NIDA-funded study. The original sample includes over 4,000 women over the age of 18 who were studied, and they were from 4 U.S. regions, generated as the primary sampling units during this actual 3-stage sampling procedure. There were 3 waves of this study, 2 and 3 involving the same subjects, 4,000 subjects from wave 1. And keep in mind that this is a non-clinical sample of adult women. These are not patients. Random digit dialing was used to target these households. There were more than one woman within a household. The one with the most recent birthday was the one who was interviewed. To get to the bottom line of wave 1 in the National Women's Study, those of you who wonder about how frequent rape is, about 13% of women reported a lifetime prevalence of a completed rape. 23% reported any type of sexual assault. 14% another sexual assault. Aggravated assault in 10%. 13% reported the homicidal death of a family member or close friend. And about 36% of the population, a little over a third of adult women, report any type of crime victimization. And the whole purpose of this study was to look at the effects of this type of victimization on alcoholism, substance abuse, as well as the development of other psychiatric disorders, including depression, and eating disorders came later, was an add-on. Most women had just one rape, but almost 40% reported more than one rape, and 5% were unsure. This was a big deal, and Dean Kilpatrick received a presidential award for these results. They were very different from what the FBI said and the U.S. Department of Justice said was the number of rapes, almost about 6 times more in the National Women's Study compared to the information from these 2 departments or what have you, governmental agencies. The reason for that is that rape goes very much unreported. 84% in the National Women's Study, the wave 1 results, did not report the rape to police. Only 12% reported the rape within 24 hours, and in just another 4% more than 24 hours after the rape. Interestingly, in terms of the age at time of rape, and I think these are really the most incredible data, 32.3% occurs between the ages of 11 and 17 years old during adolescence. That is the most high-risk time for a teenage girl or a woman. And then the next most common age at time of rape was less than 11 years old, almost 30%. So a full 62% of all rapes reported by adult women in this country occur during childhood. And as a woman ages, we go up to 18 to 24, 22%, then down to 7, 6, 3. So as a woman ages in this society, after adolescence, her chances or risk of getting raped drastically decrease. It is when one is a child that one is at greatest risk for rape. Who rapes these young women? It is not strangers. Only 22% account for the perpetrator. It's husbands, fathers, stepfathers, boyfriends, other relatives, and so-called friends of the family, other non-relatives. Okay, so the great majority are either relatives or friends of the family who are doing the raping, who are perpetrators. It's not your stranger next door. In terms of the rates of mental health problems among these rape victims, comparing rape victims versus non-crime victims, if you've been raped, the chances of developing PTSD are about 6 times greater. And note that if you've been raped, not everybody develops PTSD. Only about a third of people who've been raped will actually develop PTSD, and that brings in the interaction of biology. But I'm convinced that experience does in fact shape biology. Major depression, your chances are 3 times greater if you've been raped to develop major depression. Contemplating suicide, a little over 4 times greater. Attempted suicide, 13 times greater chances of attempting it. A lot has been done in terms of researching long-term effects of childhood sexual abuse. This comes from a very nice book that I would recommend, Incest-Related Syndromes of Adult Psychopathology by Kluft. This is a chapter out of that. This is a nice overview of all the things that have been reported to be associated with childhood sexual abuse. Not just PTSD or dissociative disorders, but hysterical conversions, depression, substance abuse, early eroticization in kids, running away, prostitution, and so on. A certain amount of re-victimization occurs, which I think can be explained through repetition compulsion. So some people see that the main difference between criminals and law-abiding citizens is that the criminals are the ones that get out in 60 days. Meanwhile, many members of our society live in fear, stay walled up in their homes, and I think this is particularly true for women. In regard to eating disorders and sexual assaults, this has been a very controversial area in the literature. There have been a lot of clinical reports of a relationship between the two, but there really has been very little in the way of well-controlled studies. And there have been 2 fairly recent reviews, one by Pope and Hudson in the American Journal, another in the International Journal of Eating Disorders, basically saying that there is little evidence that supports the notion that childhood sexual trauma is a risk factor for bulimia. The problem with the research to date is that it's involved mainly treatment-seeking or college students. No one has really examined this relationship in a national representative sample of women. The methodology has varied. The relationship between the other types of victimization, like aggravated assault, has remained fairly unstudied, even though it's fairly common. No data on relationship between the different types of victimization and eating disorders, such as type of purging, for example. Does that have anything to do with the type of victimization? And then there's absolutely nothing on this newly proposed eating disorder, binge eating disorder. So in Wave 3, about 75% of the original Wave 1 women were contacted and took part in this interview. They completed a 40-minute telephone interview, during which time they were screened for depression, PTSD, substance abuse, a number of other things, including criteria for bulimia nervosa and binge eating disorder. The average age of the women was about 46 years old, but spanned a fairly wide range. It's predominantly Caucasian, mostly African-American minority group, and this very much reflects the American women. This occurred between January and May of '92. All of the interviews were conducted by a New York-based survey research firm who specialized in doing this kind of interview. Only well-trained, experienced female interviewers were used. Now, many of you are saying out there, how on earth are people going to divulge this kind of information over the telephone? So many of you may be very skeptical about telephone interviews, and that's understandable. Approximately 85% of the women screened for Wave 1 completed the interview. 75% of the Wave 1 participants completed Wave 3. And then the data were weighted according to estimates of the U.S. Census at that time. I want you to keep in mind that these subjects responded to behaviorally specific questions designed for this present study. For example, this is actually what was said to the interviewees. Another type of stressful event that many women have experienced is unwanted sexual advances. Women do not always report such experiences. The person making the advances isn't always a stranger, but can be a friend, boyfriend, or even a family member. Such experiences can occur any time in a woman's life, even as a child, regardless of how long ago it happened or who made the advances. Has a man or boy ever made you have sex by using force or threatening to harm you or someone close to you? Just so there is no mistake, by sex we mean putting a penis in your vagina. So there was absolutely no ambiguity about the responses. Continuing, has anyone ever made you have oral sex by force or threat of harm? Just so there is no mistake, by oral sex we mean that a man or boy put his penis in your mouth or someone penetrated your vagina or anus with their mouth or tongue. And that's the essence of rape, is penetration. It doesn't really matter what orifice it is or whether it involves a penis. Has anyone ever made you have anal sex by force or threat of harm, and so on. In terms of the aggravated assault, another type of stressful event is being physically attacked, not counting any incidents already described. Has anyone, including family members or friends, ever attacked you with a gun, knife, or some other weapon, regardless of when it happened or whether you ever reported it or not? Has anyone, including family members or friends, ever attacked you without a weapon, but with the intent to kill or seriously injure you? This is the definition of an aggravated assault. In terms of the bulimia criteria, this is how we got into the binge eating. This was the so-called gate question. Sometimes people will overeat on holidays or special occasions, and we wanted to eliminate people who binged every Thanksgiving and feel guilty about it afterward. Not counting those types of situations, have you ever had an episode where you felt out of control about your eating and ate much more food in one sitting than most people? And this is really the commonly accepted definition of what a binge entails. And then if they responded yes, we got the age of onset, the frequency during their worst period, how long it lasted, their last binge episode, and very detailed questions about any use of compensatory methods to counteract the weight gain. So our definition of bulimia nervosa was based on DSM-3R. Basically, they had to have binge episodes. They had to have occurred at least several times a week. It lasted at least 3 months. And they also engaged in 2 types of binge eating behaviors, indicators of loss of control, which were proposed as bad and which are now accepted as definitions of a binge. And then compensation for a binge by either exercise, vomiting, laxatives, or diuretics. And then in terms of binge eating disorder, those who met criteria for bulimia nervosa but indicated they did not engage in compensatory behaviors and that their worst period lasted for 6 months. That's the definition of binge eating disorder. All of these interviews were done using computer-assisted telephone interview. The answers were fed directly into the computer. There was random ongoing monitoring of the interview survey as it was happening. And in terms of the results, we found no difference between the binge eating disorder bulimics and the non-eating disorder group in terms of income, employment, racial distribution. The bulimics, however, were less likely to be married or living with a partner and more likely divorced or separated than the binge eating disorder as well as the non-eating disorder respondents. We found in this study a lifetime prevalence rate of 2.4% for bulimia nervosa in adult women, with 1% for binge eating disorder. Similarly to other studies, we found depression prevalence to be about 15%, alcohol almost 6%, PTSD 12.5%. And this is really the first study of its kind to really use a detailed questionnaire about PTSD. Current prevalence was about 2/3 of the lifetime, so it tends to indicate that these tend to be chronic illnesses rather than not. And these are bottom line data. Completed rape was significantly higher in those with bulimia nervosa compared to those without. It's about twice as high. Contact sexual molestation, almost twice as high, but again, a statistically significant difference. No difference in attempted sexual assault. Aggravated assault was especially different compared to the non-eating disorder subjects, about 3 times higher, 27% to 8%. Adding them all up, again, in this non-clinical sample of women with bulimia nervosa, over half of them reported one of those types of criminal victimization experiences, compared to 31% of the non-eating disordered sample. A statistically significant difference at the 0.001 level. We looked at the rape characteristics in these rape victims with and without bulimia or BED and found absolutely no difference, whether it was a penile, vaginal rape, an oral rape, an anal rape, what have you. Series rape, with or without perception of life event, family member. None of these really panned out in a statistical way. In terms of childhood rape, and in this study we defined childhood rape like Dr. Kilpatrick did with the Wave 1 results and took at or before age 11 as a definition of childhood rape. 12% of these respondents who met criteria for bulimia versus 5% of the non-bulimic respondents, which was statistically different. There was no difference for first or only rape occurring just during adolescence or adulthood. Now, these were results that were also very hard for me to believe, but these are the numbers. And being a clinical researcher, I tend to believe my own data. But lifetime PTSD in the bulimics was almost 40%. It was something like 36%. Lifetime frequency, again, in this non-clinical sample of women with bulimia nervosa compared to those without. And those with binge eating disorder also had higher lifetime prevalence. Looking at current PTSD, still very much higher, about 22% versus the 5 or 6% in the non-eating disorders, and we didn't find a difference in the BED subject. So one might think that PTSD itself is a risk factor for the development of bulimia nervosa as opposed to the actual victimization experiences. And the way that we tried to control that was we took out all those with PTSD. So these are just the victimization prevalences among those without PTSD. We still get higher overall rates of direct victimization compared to the non-eating disordered group, and molestation was higher. All the other ones did wash out. So PTSD per se does in fact carry some risk toward the development of bulimia. Looking at it from a different way, looking at all those who were raped, rape victims with and without PTSD, the prevalence of bulimia was 10.4% in all those women who'd been raped who developed PTSD. Now, interestingly, those rape victims without PTSD and those without rape at all had absolutely no difference in their prevalence of bulimia nervosa. They were about what you would find in the general population. So PTSD does seem to be a very strong risk factor for the development of bulimia. Looking at the age at first binge episode, it tended to be earlier in those without PTSD or those without rape at all. And looking at the age at first rape compared to the age at first binge, 84% of all bulimia respondents with rapes, the rape occurred before the first binge. Looking at just adolescent rapes, 96% of them, the rape came first, and in 100% of the childhood rapes, the rape came first before the binge. So there is a chronological relationship there. There are lots of theoretical considerations, lots of theories that have been advanced to account for a lot of the post-victimization sequelae. Attribution theory. What did people think about what happened to them? Increased sense of vulnerability, decreased sense of perceived control, decreased self-esteem. These are all possible factors that could lead to an increased vulnerability to developing bulimia nervosa. Stress theory, the actual outright development of PTSD signs and symptoms is a direct result of this stress on the organism as a maladaptive coping strategy. Learned helplessness theory, I think, is a nice theory that combines PTSD and depression into as well as biological factors and helps account for the helplessness and perceived loss of control that is very, very common in patients with eating disorders. And then there are psychobiological theories that involve dysregulation of systems known to be involved or reported to be altered in eating disorder patients. We know that stress has a major effect, life events have a major effect on internal systems, biological systems, particularly the HPA axis, but then which can feed back and affect central neurotransmitter function. And there is a growing body of literature outlining the neurophysiological changes that may underlie trauma and involves just about every system that we have studied in affective and anxiety disorders, as well as, even schizophrenia, dopamine's up there. You might be thinking, what happened to anorexia nervosa? Isn't that an eating disorder too? We weren't able to ask all of the questions to make a definitive DSM-3R diagnosis. We were able to piece together everything but the menses, the amenorrhea, for 3 months. We did not have that, but we did look at all of those who were severely underweight with a body mass index below 18. We found 8 of the 3,006 with a low BMI. 7 of these rated themselves as overweight, even though they were extremely underweight. 8 of the 8 reported some degree of dissatisfaction with the current weight. So if we take those 7 who think they're overweight but really skinny and call them presumptively anorexics, that's a lifetime prevalence of 0.23%. Now, none of these reported rape, molestation, direct assault, or PTSD, and only 2 reported an attempted sexual assault. So this very much fits with the clinical literature that victimization is really associated with bulimia nervosa and not anorexia nervosa. There are several limitations to this study. We did not study men. We did not study children and adolescents. Not all bulimic respondents may have been willing to divulge such information in a telephone interview. So given that, you might think that the results would be an underestimate, although the numbers are pretty high. And then there are cultural aspects that we weren't really able to get to because there just weren't enough other cultures studied. To produce bulimia nervosa, there are biological risks, familial risks, sociocultural risks. I think we definitely need to factor in experiences of victimization into our understanding of the development of bulimia nervosa. I'm going to say just one thing about treatment. These patients are coming to you already very much disturbed. How do we help people who are already very disturbed, particularly those that we might see on a psychiatric inpatient unit? The studies, particularly PTSD in Vietnam veterans, shows that stress inoculation training and prolonged exposure both can be effective in reducing PTSD symptoms. There is a very limited literature on the psychopharmacologic treatment of PTSD, although it is beginning to get bigger. And then there are psychodynamic considerations, and I certainly would not advocate using psychodynamically oriented therapy alone, but I think there are certain notions that are helpful to keep in mind in treating PTSD, namely that we must contain our negative countertransference, and a lot of these patients probably go on or would meet criteria for personality disorders and do, in fact, engender negative feelings in us, particularly those who don't respond. Doctors don't like patients who don't respond to treatment very well. And I think the notion of repetition compulsion is also a very helpful dynamic phenomenon to keep in mind.
Now a look at women and moods by Stephen F. Pariser, Associate Professor of Clinical Psychiatry and of OBGYN at Ohio State University.
Betty Naomi Friedan really may have had more impact on mood disorders, perhaps, than in some ways some of the antidepressants, the wonderful new antidepressants that have been introduced into the market. And I say that because of an experience that I had first growing up with a mother who had to raise 4 children as a single parent and went back and did a psychiatry residency at age 40, knowing what it was like for a woman over 30 years ago to have the experience of struggling professionally and growing in an environment that was not very sustaining, to the kind of experience I've had clinically over the years, seeing women who have felt repressed and downtrodden and not been encouraged to pursue their life goals, dreams, and aspirations. And even to the quixotic experience the other day of running into a friend when we were talking and I told her about some of my work and mentioned that I'm interested in mood disorders in women. She's in the women's study program at Ohio State. And she said to me, well, of course women have depression. Wouldn't you if you'd been oppressed and downtrodden? Well, I don't know that depression is caused entirely by the psychosocial oppression that many women have known in their evolution. At the same time, we can't dismiss it either. And Betty Friedan, who was one of the more contemporary leaders in the women's movement, really has set the tone for growth and strength for women in this country by challenging the long-established American attitudes that women could find fulfillment only as wives and mothers. So I'd like to dedicate part of my presentation today to Betty Friedan. First of all, the more recent data epidemiologically comes from the University of Michigan's comorbidity study, where we see really rather striking changes from the ECA data that most of you are quite familiar with, that show us that today approximately 21% of women will have lifetime experiences with major depression, contrasting to almost 13% of men, and that manic episodes lifetime are about equally prevalent in women and men, just under 2%, but higher than reported in the ECA data. And this tells us that really, if you look at disease state management today in this managed care world, this is an area that really deserves specific and special and unique kinds of focuses. Now, what's not new is that women with depression seem to suffer more, and they suffer more in part by virtue of the fact that women tend to have longer episodes of depression. Women over 30 show increased rates of persistence of depression. In addition to that, there are other struggles that women experience. One of them being, for example, their experience with substance abuse, which is really quite different than that for men. Yes, it's true, men are more commonly alcoholics than women throughout the life cycle, but women have different experiences with mood disorders, as we'll be talking about briefly. But here I'd like to introduce, and unfortunately I don't have a sound system with me, the spiritual presence of the late Billie Holiday, Eleanor Billie Holiday, a great woman of the arts. Throughout the 40s and 50s, Billie Holiday appeared in clubs throughout the United States with great success. Although her voice increasingly showed the effects of her long-term heroin addiction, she died in Metropolitan Hospital in New York City while under arrest for the possession of illegal drugs. Billie Holiday sang the blues, and Billie Holiday had the blues. And as a matter of fact, we know that women who have alcohol problems, for example, many of them have had depression preceding their alcoholism, much more so than is the case with men. Men more commonly will develop depression with their alcoholism, although they too can have histories of mood disorders preceding the evolution of their substance state. And it's another reminder that particularly in women, once patients are detoxed, we need to be very careful about determining whether or not they have life histories suggestive of a preceding mood disorder, in which case there's some evidence now that treatment with our wonderful new antidepressants, which are much more safe with alcohol use even, may be rigorously worthwhile, or bipolar disorder may be better treated. And of course, that's an ever-growing challenge as well.
Dr. Pariser's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 25, Number 2, returns to Stephen F. Pariser on women and moods.
I would also like to remind you that women who report having premenstrual depression have significantly higher consumption of alcohol, not only in the luteal phase of their cycle, but also throughout the whole cycle. Now, a different model among women is to look at a chronic pain syndrome. In this case, we talk about pain associated with the pelvis. These are women who some years ago on the West Coast, in the Seattle area, were evaluated who presented with chronic pelvic pain and compared to two groups of women also who were going to have laparoscopies, either for tubal ligation or infertility evaluations. And the bottom line is they had much higher comorbidity rates of depression, alcohol, or drug dependence, and also, tragically, lifetime histories of sexual abuse before the age of 14 and adult sexual dysfunction. Not uncommonly, our OBGYN people will ask me to see such a patient, and it's uncanny how commonly they have the full set of associations present together. And this really challenges the best of us as psychiatrists to offer a real biopsychosocial approach to these patients. This is also relevant because we need to, as consultants to our OBGYN brothers and sisters, remind them that it's inappropriate today to operate on patients with chronic pelvic pain beyond a laparoscopy without the benefit of very careful psychiatric scrutiny. Now, seasonal affective disorder, those of you who are blessed with living in San Diego probably know very little about, but those of us from the northern latitudes know a great deal about, and that is this seasonal change business is really quite real. Women seem to have more seasonal affective disorder than men, and there are some interesting research studies wondering about the hypothalamic concentrations of serotonin in winter months, suggesting that the newer SSRI agents, among others, may be especially useful. But phototherapy is a wonderful instrumental approach to this disorder, particularly among patients who refuse to take medication or who truly have pure seasonal depression. Lots of the patients that I see who have seasonal components really have ongoing cycling, bipolar or unipolar, and seasonal treatment with light isn't enough. But there are clearly patients we see for whom this can make a dramatic impact, and also you can be their advocates by writing letters to insurance companies, and we find that at Ohio State I can get about 80% reimbursement from our health plan for patients who have seasonal depression when they get phototherapy lamps. Now, Elizabeth Weller is here, and she could address this much better, but another fascinating issue that not only applies to women but men is the issue of assortative mating, that people with like diagnoses often are attracted or drawn to each other, and when that happens, the offspring, the progeny, are very commonly affected. And that influences family dynamics and maybe stressors and kindle perhaps more difficulty with mood disorders in the parents, as well as vice versa. And so I think it is important that we have a family concept in working. And by the way, the family in this country today can represent a single parent. So I let my parents know, patients who are parents from the beginning, that if they can't get a babysitter, they should bring their child in. And I'm old enough now, I guess unfortunately or fortunately, depending on how you look at it, that I've had the opportunity even to treat some of the offspring. And whenever possible, I work with Elizabeth and her group, and we've shared some interesting patients together because of this. And I think it is so beneficial with women and men as well to see significant others and family members that I really can't stress that enough. So often a patient will be bipolar and they won't present with classic bipolar symptoms, but when you bring a significant other in, they will validate this. Not long ago, I saw a very interesting patient who was referred to our clinic. This happened to be a male patient who had psychosurgery for temporal lobe seizures and continued to have outbursts, and his 14-year-old daughter came in with him, and she wasn't the identified patient, but she was the victim of his verbal abuse when he had these breakthrough spells. And so I ended up seeing him with his ex-wife and 14-year-old together. The 14-year-old doesn't want to get identified help, but it's been very interesting from that perspective as well. Now, everyone knows about Kreplin's dysphoric mania or mixed bipolar states. For women, it's an important issue for two reasons. One is these patients don't tend to respond to lithium as well as we wish they would, and so they're often better treated with divalproxodium or Depakote or carbamazepine. I prefer the divalprox generally because of its drug-drug interaction profiles. And second of all, because women with this diagnosis are more likely to have more hospitalizations and a more morbid course. But even more startlingly is the issue of rapid cycling, where most studies suggest that the preponderance of patients with rapid cycling are women, and this is again a situation where lithium is often not enough or doesn't work, and so we frequently again will use anticonvulsants in this group of patients. Now, one can really draw on marvelous sense of pain and experience in looking at mood disorders by focusing on some of the great people of the arts, as I mentioned earlier. In fact, not often I will actually draw upon this notion and invite patients to read a contribution to literature or listen to music that shares the pathos of their experiences to help them connect and see how even great minds and great people can survive and endure and contribute. This case, talking about, of course, Virginia Woolf, an English writer, a wonderfully interesting woman, and her sister Vanessa, a fervent supporter of women's rights. Woolf considered the difficulties of the woman artist in a room of one's own, and on March 28, 1941, and by the way, she appeared, by the work I've read of Virginia Woolf, to have a mixed rapid cycling bipolar disorder, to ultimately walking into a river with rocks weighting her pockets and committing suicide. Very creative at times, unbelievably classic descriptions of mixed bipolar disorder, and probably the best description of mixed bipolar disorder that I've ever read was Gustav Mahler's. And of course, if you're Mahler fans and listen to Mahler's symphonies, you can appreciate that. Suicide is an issue for women as well, even though men commit suicide more frequently. The suicide rate among single women under 35 is twice that of single men of the same age group, and over that pattern the numbers do reverse, but suicide needs to be taken seriously in women as well. Now, China and the great Congress for Women's Issues that was held there recently, suicide is the leading cause of non-natural deaths in China. The female suicide rate is higher than in men, and in about 2/3 of all suicides, men and women, family disputes and love disappointments are precipitants. Chinese women are of low social and economic position, as you all know, and this perhaps does make the point that we cannot just focus on drug therapy in these patients, but need to look at really a holistic biopsychosocial perspective. Still needing further study of this interesting area of premenstrual depression, or PMS, still under investigation, now called in the DSM-4 as premenstrual dysphoric disorder. These women are hard to find, actually. If you do studies, you have to interview large numbers of women to find women who have this purely isolated luteal depression, because so many of the women do not confirm prospectively. As a matter of fact, in most studies, only about 50% of women who come in, if you put an ad in the paper and say you want to evaluate women with premenstrual depression, only about 50% of women who are prospectively confirmed with charting will actually have this kind of isolated depressive experience. In fact, in the community, evidence suggests, and it should be no surprise, that women are in fact quite hardy, and that very few women have severe premenstrual depression. And that's not to say that women aren't cognizant or aware of changes in their menstrual cycle physiologically and psychophysiologically, because they are. But it does mean that when women present to your office and say they have PMS, they're more likely probably to be in the severe category, and that seems to have special meaning. And one of the curiosities of this epidemiologic study done in Calgary, Canada, is that 7 out of 8 symptoms at the strong and severe level showed no increase in the prevalence in the premenstrual compared to the other menstrual cycle phases, even though the women identified themselves as having a luteal phase disorder. Another compelling report demonstrating that when a patient presents with PMS to you, they're now looking not just in the community, but those women who come in seeking help, that they have high rates of functional impairment with social relationships with children, with partner, with household chores, with work relationships and performance. Not long ago, a colleague asked me to see his wife, and she presented to me telling me something I had not known before, and that is that her husband, in fact, had AIDS. I knew that he was gay, and I didn't know they were separated, and that she had terrible PMS. And in fact, she had such terrible PMS that she and her children were seen in counseling at the Children's Guidance Center associated with Children's Hospital, and her therapist there was concerned that she was constantly lording over her children the notion that she might kill herself because it was all too much for her. When I evaluated her carefully, she had a rapid cycling mixed bipolar disorder, and has substantially improved with a combination of psychotherapy and divalprox sodium. We may need to add an antidepressant, but she presented as PMS, but careful assessment and untangling of symptom profile revealed, in fact, that she was bipolar. And this makes the point as well. If you look at women who confirmed having PMS in their lifetime diagnoses, if they had no psychiatric diagnoses lifetime and confirmed, that was about 55% had no psychiatric diagnoses, but luteal phase dysphoria. If they did not confirm and had only about 13% had no lifetime psychiatric diagnoses. And among patients who presented and were prospectively evaluated who had PMS confirmed, 30% had lifetime diagnoses of major depression, and PMS not confirmed, 58%, almost 60% had lifetime histories of major depression. So we commonly see women who have exacerbations of an ongoing mood disorder as compared to or in contrast to luteal phase symptoms alone. And while there are a multiplicity of treatments available, in fact, very few of them stand the scrutiny of double-blind placebo-controlled trials. But I'd like to talk with you briefly now about a heuristically interesting way to approach these patients that really challenges some of our notions about treatment. Here we're talking now about the use of a GnRH agonist, deproluprolide, a synthetic analog of naturally occurring GnRH that suppresses ovulation by inhibiting the release of gonadotropins, and it's a lousy way to treat PMS for a couple reasons, one of which is by causing menopause. In effect, these women then develop vaginal atrophy, hot flashes, and risk of osteoporosis, so it's not something to be considered lightly. It's certainly not FDA approved, and I don't recommend it, but in terms of study, it's worthwhile. What was found here in these patients in a double-blinded, placebo-controlled 6-month crossover trial that irritability, neurologic symptoms, breast tenderness, and fatigue responded best. However, in those patients with moderate premenstrual depression, there was improvement, but they still remained clinically symptomatic. And that those with severe PMS showed absolutely no improvement at all. Now, there is debate in the literature among scientists with reference to the impact of serotonin on the luteal phase symptomatology picture. At the same time, there has been some data that suggests that the platelet uptake of serotonin is low, and serotonin levels in peripheral blood are lower, perhaps controversially at least, in women with PMS. And so there's growing interest naturally in the antidepressants. The first studies with antidepressants and PMS, the first one that I'm aware of was Wilma Harrison's work using nortriptyline in an open trial. But now, in fact, there are multiple trials with the SSRIs, several SSRIs, and also with nifazodone. Fluoxetine, in Meyer-Steiner's work from Canada, published in the New England Journal, single-blind placebo washout period lasting 2 cycles, randomized double-blind placebo-controlled trial of fluoxetine at either 20 milligrams or 60 milligrams a day or placebo. 180 women completed 6-cycle treatment phase, moderate and marked improvement in a substantial number of these patients compared to placebo. And the 20 milligram dose seemed to work as well as the higher doses and led to fewer side effects. More recently, my colleague Kim Yonkers from the UT branch in Dallas put a multi-center trial together looking at sertraline or Zoloft in PMS, and also found that while 40% of placebo-treated subjects responded, that 70% of sertraline-treated subjects showed clinically significant responses. And so we have evidence now in double-blinded trials of fluoxetine and sertraline, and an open trial with nifazodone or cerazone also shows benefit. Now, PMS treatment recommendations, all that considered, include the fact that in patients who don't have obvious historical evidence of lifetime mood disorder in a traditional sense, that sometimes it's wise to prospectively evaluate them, even if you want to, in some cases, to document ovulation. But for now, the best treatment do seem to be antidepressants throughout the cycle. And while one of the great physicians in literature, Anton Chekhov in the Cherry Orchard, wasn't writing about PMS, I think we do need to be humble here. Chekhov said, if many remedies are prescribed for an illness, you may be certain the illness has no cure. That's the case with PMS, and I would add that we still understand, in fact, very little about it. If you look at the OBGYN literature, even the OBGYN people are getting hip to this now, where Dan Michel in last year's and even this year's yearbook of OBGYN say things like, it's puzzling why agents such as progesterone and pyridoxine have not been shown to be superior to placebo, are the most widely used therapies for PMS in the United States. Now, moving on throughout the cycle of life into the postpartum intervals, we'll talk about the postpartum blues, postpartum depression, postpartum mania, and postpartum psychosis. Michael O'Hara is a research psychologist, and he did this interesting work looking at women who had this 2 or 3 days of blues after having a baby in the first 2 weeks. As you know today, women are home after having a baby after the last ligature is secured on an episiotomy, as we strive for excellence in managed care. And as a result of that, we don't really see many of these patients. But his data suggests, in fact, that if you have postpartum blues, you're more at risk for postpartum depression, previous episodes of depression, and premenstrual major depression. So in identifying women at high risk for mood disorders, you can see a pattern. I always ask my patients about luteal phase dysphoria. I ask them about postpartum experiences. I ask them about a variety of things that all are high-risk potentially identifiers for further difficulties. And while it's true the prevalence of postpartum depression is about 10%, the fact is, as good psychiatrists using good clinical epidemiology, you know that that's not the way to do business. That our mission as good clinicians is to identify the patients at high risk and put them into high-risk protocols for follow-up. And so the patients who've had PMS, who've had postpartum depression, who've had postpartum blues, who've had manic depressive illness, they're all much at higher risk for these kinds of experiences. In fact, just this week, we saw a patient referred by OBGYN who had a terrible psychotic episode with her last pregnancy, no other experiences with depression under any circumstance, some history of PMS, and she wants to be prophylaxed with this pregnancy. We saw her 10 days postpartum, and I presented the options to her, and she has decided to actually prophylax, and there is some data now supporting that approach in some cases. Some of you may already know this, but one of the curious things reminds me of the line from the HMS Pinafore, "Things are seldom as they seem, skim milk masquerades as cream." You know, if you'd asked me what I thought caused postpartum mania, I would talk about the hormonal changes, not really understanding what I meant, of course. But Tom Weir really challenges all that. He looked at 2 different sets of data from different studies and found that women who had babies who were bipolar had the same high rates of mania postpartum as men who were bipolar whose wives had babies, raising the issue of the challenge of psychosocial stress and also sleep deprivation as being really viable triggers here. Postpartum psychosis is horrible. It is really, really horrible. 1 to 2 per 1,000 live births. The majority of these patients, even with psychotic symptoms, have mood disorders. They're often bipolar. And the risk that a woman with affective psychosis will have puerperal psychosis is 20 to 25%. The risk that a woman who's been psychotic will be psychotic again postpartum is even higher. So these are very, very, very attention-deserving patients. Now, the area of menopause has changed quite a bit. First of all, you know, if you look in the community, you all know that the epidemiology in the community tells us that older adults in the community have lower depression rates than younger adults do. The reason for that, ironically, may be that the hardy survive and that the patients with the mood disorders, you know, if you have depression and you're 50 years old and followed for 15 months, you have a 4.3 times higher mortality rate from cancer, pulmonary disease, and other medical complications. Some of these patients have committed suicide. So in the community, we really may get a kind of a skewed sample here. Nonetheless, when we look at even the most recent data from the University of Michigan, we find that in fact there isn't more depression in the community in women, among women who may be considered menopausal. However, the significance of that has to be taken in a different vein. Let me just share several other studies with you that I think are important for your consideration. In Harlow's work, 14% of cases of early menopause under age 46, by the way, the average age of menopause in this country is about 51 years, reported histories of medically treated depression at least 1 year prior to menopause, compared with 6% of women reaching menopause after age 47. So it may be that the early menopause folks are at higher risk for problems, and the perimenopausal period may be a particularly high-risk period. An association of medically treated depression in early menopause is greatest in women with menopausal age before 40 and in women with a history of medically treated depression requiring more than 3 years of treatment. These are women at higher risk. In this study by Hay and others in the British Journal, of 78 women having gone through natural menopause, 35 had chronic current depression with a clear peak of illness seen in perimenopausal period. 35% of all patients with current or past depression experienced their first episode during perimenopause, suggesting that in fact it is the perimenopausal zone, if you will, that might be most important for consideration. Now, one of the interesting questions that I'm asked frequently, and I'm here to tell you that I don't have the answer yet. I've just submitted a protocol with Kim Yonkers for review by a major drug company to look at the issue of estrogen in treating depression and comparing it to estrogen plus antidepressant agents. And that's probably a good idea, I think, because of Gary Small's work and Lon Schneider's work, which suggests when they looked at a large sample of older women patients, first of all, very little difference in placebo and drug treatment groups in response to, in this case, fluoxetine. But when they teased apart the women who were on estrogen replacement regimens, they found that the difference was clearly accentuated between drug treatment and placebo in favor of combination therapy. So estrogen replacement therapy may be strikingly important in getting the best results possible in perimenopausal and menopausal women. We need more data on that. Now, I don't have time to address this fully, but not only do women have different kinds of experiences with mood disorders, but they also have differences in their response to medication that really mandate further study. You know, most of the early studies have been done with men for obvious reasons. Differences in response to psychotherapy are even noted among women, with women doing better in group therapy and more problem-solving types of therapy than men. And actually, I remember data, I do some work with sexual dysfunction as well, among men with premature ejaculation who were asked whether they'd rather have a behavioral approach or take an SSRI. The vast majority of them would rather take a pill than get any counseling or behavior therapy. So there are, I think, different levels of receptiveness to treatment and kinds of treatment that are worth considering as well. And then there are some of the other psychodynamic and pharmacokinetic issues. Absorption, women may secrete less gastric acid than men, may have slower GI transit times, body fat to muscle ratios favoring fat as we get older, women particularly. Progesterone and estrogen have been reported to increase or decrease, respectively, monoamine oxidase activity. And remember, as we get older, all of us have higher levels of monoamine oxidase activity, which might be an important factor in older adult depression. So from a treatment perspective, I'd like to make several points in closing. One, women's mood disorders are different and linked to their life cycle than men. They're different in several ways. They have unique experiences, premenstrual type experiences, or cycling, even with bipolar cycling links to the menstrual cycle. Very unique and interesting postpartum kinds of experiences with mood disorders, and even during menopause, some interesting issues being raised now. PMS is linked to mood disorders, but clearly the best double-blinded controlled evidence we have suggests that the antidepressants are best. I favor the shorter-acting SSRIs as a rule because of potential of pregnancy exposure. The history of mood disorder confers increased risk of postpartum mood syndromes. It clearly probably does. And a link between menopause and depression is uncertain, but the perimenopausal zone may be especially a vulnerable time for women. In closing, I'd like to draw attention to Emily Dickinson. You know, Dickinson lived in Amherst, Massachusetts in her adult life, and after the age of 40 became reclusive and wore mostly white. She was very prolific, wrote an enormous number of poems, over 2,000, and yet very few of them were ever published, reflecting the time and the role of women in society at that period of time. From excerpt from poem number 712, obviously Emily Dickinson had a mood disorder. Because I could not stop for death, he kindly stopped for me. The carriage held but just ourselves and immortality. We slowly drive, he knew no haste, and I had put away my labor and my leisure too for his civility. Dickinson, Emily Dickinson, talking about, I think, her own somewhat autobiographical experience here. And then from the first day's night had come, and something's odd within that person that I was in this one. Do not feel the same. Could it be madness, this? And so really, the challenge of addressing mood disorders in women is an exciting one. Psychiatrists have always been folks who, I think, have had a sense of a missionary notion of helping the underdogs evolve and grow and nurture. And in many cases, women have not had the benefit of healthy societal and familial support. We have a special opportunity here then to combine from a biopsychosocial perspective the concept of good medicine and good psychosocial intervention to really offer many women the opportunity to not have to experience the lifetimes of agony of an Emily Dickinson or Billie Holiday.
Thank you, gentlemen. Audio Digest Psychiatry is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1996.